Hi, my name is Magnolia Contreras. I am the Vice President for Community Health, and I've been at Dana-Farber for 15 years. What led my career into public health, in essence, is when I was in college, I had a summer job at a community health center and discovered this whole notion of community health and was hooked from that moment. I was able to work with new immigrants and provide them health care, preventive health care that I think for many immigrants that were coming to that health center, they didn't know anything about that. It was a foreign thing to have preventive health care. You only went to the doctor when you were sick. And when I started to really think about and learn about community health, I went to the literature to understand, like, what is this concept of community health care? And it was really a model that was developed in the United States, but really rooted in work that was being done in Africa and how healthcare was delivered in Africa. And our local leader in the community healthcare movement, he is from Boston, Dr. Jack Geiger, took those learnings and brought it here, and then worked with our government to help fund this idea of working to improve the quality of healthcare for poor communities. And he started the model here in Boston and in Tennessee. And we have expanded it here in Boston and have over 50 community health centers. And that experience really is what led to what we now can connect to, that type of work, to public health. And then cancer evolved primarily because I was doing advocacy work I was doing maternal child health, HIV/AIDS, pediatric HIV/AIDS work, chronic disease education and outreach. And then cancer was just, for me, another disease with the same strategies that I had learned, and wanted to ensure that those who were not aware about cancer became aware. But that was after I had my own cancer diagnosis, and believe it or not, I landed here, and then it became clear to me that I landed here because I had a purpose. And so I've stayed here that long because both my personal experience and recognizing that it was unique at the time and being able to talk to community about this notion of cancer survivorship, and then, fell in love with Dana-Farber, our special sauce, and the continued work we have to do to reach out to communities and raise awareness and allow the community to understand that we're here for them. And that's really been the evolution of how I've been here for this long, 15 years. I came to Dana-Farber after I concluded my cancer treatment, and I believe I was probably in the 2-year post-survivorship cycle, so likely about 2 years post-treatment care and some time off for healing. And during that time, I had also taken advantage and gone to business school, and so I came here just immediately after that. I came in as Director of Community Benefits, and at that time, the role was basically to ensure that what we were doing met regulatory requirements. So it was very narrow. But because I had so much experience in program development, grant writing, operationalizing programs to meet community need in the prevention space, over time, I became the person to manage and oversee many of our outreach programs. Two of our longest running programs are, one, the mammography van, which is our flagship program. And the mammography van is where we bring our big van and park it at a community health center, mostly, and women come on the van to get a mammography. Right on the van, we have state-of-the-art technology on that van. The Blum van, today we use it primarily for our Sun Safety Education Skin Cancer Screening Program, where in that van, we go into beaches primarily, and we have a dermatologist inside the van who does a full body scan. looking for areas of concern for patients. And if we find something, an abnormal finding, we then follow up with those participants and make sure that they get the correct workup that they need. And we also expedite any appointment that they might need if they come back to the Brigham dermatology program. These last 2 years, 1 year we couldn't run because of the COVID year, and last year and this year we are planning, we have to run it with COVID protocols. So one of the things that we had to do was really become nimble and retool how we did our work in community benefits. And one of those ways was to look at how do we continue to provide our important programs in cancer screening and prevention during COVID so that we can continue to save lives and still go into the community and provide, for example, our skin cancer program. And so we had to develop a protocol in order for us to do that met the City of Boston legal requirements and Dana-Farber policies, and our team was able to do that. So our work with community health centers really is based on our mammography van model. Most of the sites that we participate with and attend are community health centers. We have an agreement with those community health centers where we become their imaging site. So our program is very clinical. It's as if patients walk into Dana-Farber brick and mortar. That's the caliber of program that we bring into the community. And with that being said, we partner with, I think right now, somewhere around 18 to 20 health centers. And those relationships have been almost 20 years or as old as the mammography program have been. One of the areas that we are interested in is trying to figure out how do we expand and strengthen those relationships with those health centers. And some of those health centers, by the way, have asked us to do more. The patient navigation program is one of our most exciting and new programs that we've implemented in the last year. And the goal with that program is to identify the patients that are coming in to our doors, identify them early, identify their needs early so that we can intervene and help them come into Dana-Farber with a warm welcome and supports throughout the cancer course. It's that simple. But what is unique and important about it is this idea of preemptive connection with the patient. And that's really the uniqueness to the program. So what happens is a patient is on a schedule. They get referred here by a community provider or anywhere. We have too many doors at Dana-Farber for patients to come in through, but we identify them through our reporting mechanism. And the navigator does a chart review, talks to the right colleagues that are in our team to identify issues. Then we call the patient and we conduct a brief needs assessment. Gives us a sense, a profile of the patient before they come. They get asked if they'd like us to be here to meet them on their first appointment. Most patients say yes. So our navigators are here meeting patients at the front lobby to usher them into, for the patient, this cancer space, to us, to our environment. And then they start to work together. And then we work with our clinical teams, and the patient gets to build a relationship with the navigator. And from there, the patient gets to decide how engaged they need the navigator. We also get to understand the profile of the patient, literally how they are showing up here, which having a cancer diagnosis is a big deal for people. Never mind if you come from a community that has been historically marginalized, that you come from conditions that where cancer is just another social burden for you. And so we want those patients to experience survivorship in the way that we talk about it here at Dana-Farber, that special sauce. And many of our patients from communities of color don't have that experience. They have told us through our needs assessments. So we want to be able to bring our services and to bring those patient experience up to the level of general Dana-Farber patients, and it takes a navigator to hold the hand of those patients, walk with them as long as they want us to work with them, and be able to say that these patients went through a cancer experience, but that they ended up in a much more healthier state, and for us to be able to bring them forward to allow them to take advantage of the survivorship aspects of a cancer diagnosis, care, and treatment. That's the vision of what our navigators are doing. They're doing it lovingly, committedly. It's not easy, but that's what we really want to see happen. Now, you might be asking, how is that different than what we do with all our other patients? It isn't that much different. The difference is this idea of this rapid response, not waiting for the patient to not show up for appointments, not waiting for the patient to eventually feel comfortable letting their providers know that they're having issues, maybe not enough resources for food, not enough money to come to their appointments, whatever condition, maybe that the home state may not be safe for them. We don't want to wait to hear and to know about those things. We want to have a sense of those things early and intervene. We started during this pilot phase by identifying our priority neighborhoods, right?